So I guess it's time to get started. Can I get a motion to approve the minutes from last month? Okay. Correspondence. Looks like Rensselaer Volunteer Ambulance has deactivated the agency code. Agency is no longer an ambulance service in accordance with Article 30 and may not respond to requests for emergency pre-hospital care or transport patients. And new controlled substance notification for Bruin RS. Rescue Squad paramedic Mark Fusco has assumed that position. Committee reports. Don, back it up.
So academic was actually pretty short. The main discussion was talking about the transfusion protocols and the fact that Wadsworth Lab came and essentially talked about the fact that, at least by their interpretation of the regs, you need to be an ambulance transfusion service, of which they're a tenant in the state, to be able to transfuse a patient with blood or blood products, and that a nurse or physician on board a regular ambulance was not sufficient. There was also detailed rather difficult procedure to become a transfusion service, but Beth McGowan has actually the slides if anybody wants to see those. So essentially the way they left it, and that may not be exactly how it is now, but essentially they left it is if you were to transfuse, if you were to take a patient with a nurse or a doc on board that was an ambulance transfusion service, they would first send you a letter saying, you guys can't do this and this is how you become a transfusion service. The next time they give you a warning, and the third would be a citation from the health department. What that citation would be is not clear, but according to them, it would be going to the ambulance service, to the hospital, who basically has a permit for transfusion services, and also for the provider who is on board.
Are any local agencies transfusion services?
No, Empire is. Empire has been certified as an ambulance transfusion service. What's left to be done, and I'm actually in the process of doing this, is perking up my ears, is they have to have signed contracts with the transfusion directors. So this gentleman, Dr. Zinsky at St. Peter's, I've been in contact with. So we're actually working on that. So right now, Empire is able to do it, but you have to have a signed contract. So if you don't have a signed contract, you can't call Empire.
Well, I also have to have a signed contract with every hospital.
That's right.
And initially it was said you needed with every hospital that you come from and every hospital you're going to. I don't know if that was reinterpreted. Somebody said that was reinterpreted just being sending hospital.
Yeah, they
Sending.
clarified
They
that
clarified
during the meeting. They clarified.
So that would answer your question. I guess Empire would be the only one that we know of.
So they also did say in this new interpretation that the education to the CCs and paramedics had to include the doctors of the directors of the transfusion services.
Each doctor of transfusion service.
Yes.
So
Yes.
Empire then
Had to
needs
approve it.
education from
Every hospital,
Yes.
which just,
Yes, Bruce, you're not,
I'm sorry, what?
you would not be sufficient. Or whoever's invited with for one time.
it was medical directors and the doctors from
Of
the
the
transfusion services to help with the
When does the
education.
change occur?
This occurred at CMAC. Wadsworth reinterpreted the rules, saying that we're going to make this much easier for you to become a transfusion service. Here are the 30 steps you need to go to be able to do this.
Only in New York.
However, they did not say that existing ambulance transfusion services did not have to change what they were doing.
I guess if you already had your.
Right, if you already had everything in place.
Okay. So just to let you all know, so you can call Empire, is they were certified a year ago. So they're golden.
Other than getting.
Or that's going to make
contract.
Mohawk and all the other agencies a lot more difficult.
Is there any intent to bring this back for further discussion, Don, for regulatory or what?
Now that you brought that up, Sam. The letter went from the CMAC to the commissioner unanimously from all the docs, basically stating that this needs to be reevaluated and please consider not enforcing this regulation until we can basically resolve it, because this is putting patients' lives at risk.
Absolutely.
And as simple as someone going from Samaritan to the Med, or
Right.
from St. Peter's to the Med. I mean, it doesn't have to be someone that Beth's just transporting from,
programs even have this?
Yes.
They do.
And their concern is, I guess they were looking at 170 contracts that they were gonna have to come
172.
And the other
up
thing
with.
that you.
And each one had to be negotiated.
So they have the certification, or they're having
They're
to
working
get it?
on it.
They are working on it. I've been working 2 years on it.
So
That's how onerous it is. And the other thing they said is that new forms will be coming out, but they're not available yet, so you may need to update your program with the new forms.
Don, what if a physician rides with the patient?
According to Wadsworth, no matter if it was a physician,
So,
PA, nurse,
yeah, there's a couple of core components here that were most silly, right? The first is that they actually didn't read their own regulations. They misinterpreted them according to every attorney that I've run these regs by so far, has said, no, a nurse or a physician is absolutely fine to transport blood. It's just a paramedic that needs this ambulance transfusion service. And then within the ambulance transfusion service regulations, it very clearly indicates that if an ambulance transfusion service is not available, anybody can do the trip, because they wrote the regs the right way, saying we still need to be able to take care of our patients. So the regulations are actually not so bad. It was the way that they chose to implement those regulations and the processes in place. So ASAP's already working on this. There's a group of folks that are very actively engaged in trying to put forth basically an answer to the department that the department can then hopefully accept and move on from, by saying thank you rather than this ending up being a battle, because very clearly this is potential for harm.
So we'd be safer if nobody had this certification, because then there isn't one available and we can just take care of the patient.
Well, because if, the other thing would be that it's just like any other operating authority, right? If, you know, you call the service that's supposed to do the trip, the
Right.
service is unavailable, then you just
Right.
call the next ambulance,
Right.
and that's fine.
so it's a little bit in limbo at the moment. I can just say that's how they basically left it, as Mike said, being worked out. What you do at this point, I guess, is kind of,
Well, I think what we recommend from this body, and frankly, I would make the motion, from this body, we make the recommendation that if you are asked to transport blood, or to transport a nurse with a patient with blood, do it. It's the right thing for the patient. We can defend the higher moral ground. Let's just do the right things for our patients.
do you wanna make?
No, I was gonna say, that was my question. So tomorrow, if I'm working at Samaritan and I need to transfer somebody down to Albany Med with blood hanging, can we do it? I mean, Mohawk is our contracting ambulance company. Obviously, a nurse would have to go, but, so it's okay to do that then?
My answer would be absolutely.
Yes.
I guess,
If Mohawk will do it.
yeah.
Well, I understand that,
If they're
but
nervous, they may say
but
no.
I'm sure there's liability everywhere. It's not just on
For
Mohawk,
sure.
liability everywhere.
Yeah, I mean, I don't know, we can make a motion that this body wants that to occur, and what the health department's gonna do is another question, if anything. I mean, I agree with Mike, I would take the high road and do whatever's best for the patient, and whatever fallout comes after that is easy to do.
Clearly, if you're transporting from one hospital to another with blood, there's a need for it to happen.
Right, exactly. And, you know, it'd be tough, I mean, it'd be really tough if you were gonna enforce something to come back and say, no, you know, this patient should not have had, you know, you couldn't transport them, so harm's gonna come to them by not doing so, and we're gonna enforce that, I mean, that makes no sense to me at all.
The other piece of law that was discussed was EMTALA as well, being a federal law versus the state regs.
Because EMTALA requires the stabilization of the patient.
Mhm.
So part of the stabilization of the patient is the transporting of a patient with blood. That's required for the stabilization of the patient. Does the federal law apply? Probably not, was the interpretation that came back, but it's an interesting and creative part of the solution, which comes back to the regulations say we can do it. So do it, and it's the right thing for the patient.
And the EMS regs only say that there needs to be an agreement with the hospital. So,
Right.
the section in Article 30.
So for the short term, until things get further delineated, Camp Lowry just put out a supporting advisory that right now the practice should continue as it currently is. And then as things roll out further, we can make changes, and this will help support anyone who has concerns. stronger if we vote on it.
I think we should.
Okay.
Do we have a specific wording? Or can we just put an advisory to continue to transport as currently, per the current
Current
regs?
process, we'll utilize the current ambulance transfusion service process as it is currently written. And if they come up with something different down the road, then fine, we'll deal with it then. But for right now, we need to go with, as of this date, these are the rules we're gonna follow.
I think what I would say for specifics, you probably want to say that the Remac endorses the fact that transfusion of blood products between hospitals must occur. And we support hospitals making decisions to transport those patients utilizing staff or ambulance transfusion services as available.
In a timely fashion. Because yes, we could get Empire, but if Empire's gonna drive an hour to get to you.
Correct.
Yeah.
So, if you want that word for word, you're gonna have to write it down, because I can paraphrase it, but, for the minutes. If you're gonna make a motion.
How about we make a motion that says, we will write something with the intent of making sure that care for our patients continues, we will wordsmith it offline.
That sounds like perfect.
Yes. So we'll be here till 7.
Right.
So, somebody wanna make that motion? Mike,
You
can
might
make a
want,
motion.
you might want to just include some sort of wording, Mike, that says, based on treatment appropriateness and safety for the patient.
Good idea. Very good idea.
Because it's a patient-centered advisor, and let's put that in the wording in some way. That we're acting on the advisory for the benefit of the patient.
I want you all to know, it came out, Mike was an English teacher. Just so y'all know, that's why.
For real?
For real.
Seriously?
Wow, that explains so much.
Click, click.
In his previous life. And right, that explained a lot.
Yes, it does. New fun fact.
When that advisory is written, could someone please forward it to me so that I can take it back to Aarons and get them to do the same?
Sure.
I would like a copy too, and I purposely don't want to be signing or doing anything because I'm pushing St. Peter's Health Partners to currently sign these transfusion agreements. I don't want to feel like I'm working on both ends.
I think we've been working with Mohawk for several years to try to get all of these done, so this is not an easy process for people to do.
Well,
Don't
Empire
worry,
is in
it's
the
much
lead,
easier
but
now.
I would hope Mohawk steps up. I think there should be more than just one agency.
Yeah.
So anyway, so Mike, you made the motion, I seconded it.
All in favor? Anybody opposed? Okay. Anything else for academic?
The protocols will be on, hopefully, be on and past the next CMAC agenda, which is in January. And if anybody has any additions or corrections of what currently stands, please contact the people from the collaborative protocol.
So for REMSCO, Bethlehem EMS Director Ryan Greenberg was introduced to REMSCO, and they're looking at moving us. I think it's, I want to say 5 Washington Ave extension or something like that.
We are moving.
We are moving.
The end of the year, through 5 Washington Square, which is down the road right off of Washington Ave Extension. Our lease is up here in December, and it's just the best thing to do, so. The REMSCO supported my suggestion that we leave this place and move into that place. Well, I'll let you guys all know as things transpire.
Are they gonna give us a plastic wall for?
That plastic wall's gonna go with us, yeah, we'll use it. I built that place.
Anything to add from CMAC? You're pretty much,
That was basically it. I can't remember anything else. Semsco, Mike, remember anything else?
okay. QI? Any meeting this month?
Yeah, we went over CARES data, getting good numbers, still need some input from a few of the areas, agencies, and from some of our local hospitals. Then I think the big thing was Art had brought up the documentation standard for making sure that charts arrive at the med. So I think there was a plan to create a documentation rule, is that right, Mike?
It's a documentation rules committee,
Okay.
basically to put together some regional documentation standards for chart closure. Paul Segru was on the phone at the moment, so he was immediately appointed chair of that committee. But if anybody's interested in participating in that, it would be fantastic. Please email Paul.
They did mention at Semsco that they're talking about a hospital hub for delivery of these image trend charts. I don't know what else, what other ones.
And then, lastly, Mike's restock forms, nurses will use that and will restock BVMs, correct?
Yes.
Yep, okay. I think those are the big points from Mark, you and me.
Any way we can encourage restock BVMs with peak valves?
Don't forget.
Depends if the hospital stocks them.
Zip it down there, will you?
If we can get macro bore extension sets too, then.
Oh, that would be fantastic.
Can I just ask a clarification? Because I probably misheard it, that nurses committees decide they will or will not restock BVMs?
Will.
They will?
Will.
Oh, that's-
Will.
On the list for the restock form, actually glucagon was still on there.
Okay.
Glucagon is now off the list, and BVMs are now on the list.
So we
Yeah.
can do 400 BVMs to replace a 1 to 3.
Yeah, exactly.
In fair trade. Tim?
Thousand.
Cox?
Oh, the Hawk met on September 12th. Couple topics, they're both related. They are updating their mutual assistant agreement with all the member partners there, and they're updating their ops plan, which basically mirrors their mutual assistance agreement. Just so everybody, all the membership is on the same page. And that was about it.
Agency upgrades, updates and upgrades, really nothing except for public access. St. Jude's, Spidey Group, Dynamic Systems, Wildwood Latham, FB Petco's Company, National Racing Museum, and Mechanical Police Department updates. For PAD, new business.
Just one note before I leave the public access.
Yep.
I just learned that Jen Nichols isn't doing that anymore, so if you're doing that, it's now Deb Cuffs. So as we send in our notes, it's to Deb, not Jen.
Okay. Most still work?
Folks, we have Scott Skinner, he's the Administrator Chief of Malta Stillwater, and their Medical Director, Dr. Todd Fowler. They're gonna present their RSI plan.
Doc, go ahead and start.
Almost lost your cup there, you're taking Jay's head off.
That doesn't hurt, does it?
Please go ahead and second.
Go ahead, Doc.
Okay. This was emailed out to everybody over the last week. I hope everybody had a chance to look over it ahead of time, and if you have any questions, just jump right in. Basically, Malta Stillwater has been a combined agency between the towns of Malta and Stillwater for the last 5 or so years. I've been their medical director since around 2001. The call volume is progressively increasing. The severity, patient acuity is progressively increasing. We're taking a frequent critical care patient out of multi-med emergent care. And we feel that it's in the community's best interest to allow us to progress forward with MFI, RSI, however you prefer to word it, for our paramedics. We have run an initial training course for those members of our agency who have not been credentialed at other agencies. If you remember, we have agencies on either side of us Clifton Park Half Moon and Wilton are already RSI agencies. We share a lot of staff with them, so many of our providers are already credentialed in the region to perform RSI. Over the last couple weeks, we've run an internal course to bring our non-credentialed providers up to this level. It'll bring our total numbers up over 20 of credentialed providers. Do you want to talk about our staffing?
Sure. We have 62 employees, 33 paramedics, we have 6 volunteers. Right now we have 23 credentialed paramedics, and to us, you're either an RSI medic, you're either in or you're out. So our goal is to get as many possible as we can. We have 6 that are gonna be doing the training on Friday, so that should bring us up right around 29. Out of our 33 medics will be RSI paramedics. And Todd laid it all out. It's pretty much what we're doing with Multimed. We have a volume, we're doing a lot of drips out of there, a lot of pumps out of there. We're making a move to go towards SET level, and this is a step. We're getting a vent pretty soon, a couple vents pretty soon. And that's where we're looking for your support to go in that direction, because we're getting sicker and sicker people. They're going to Multimed and they're sick. And there's quite the transport time to Albany. You know, a lot of them go to Saratoga. Probably close to 60 to 70% of our patients go to Saratoga Hospital, but still a lot go to Albany. And if they need special services, they go to either St. Pete's or Albany Med. And a few go to Ellis, but most of the time, you know, if they're real bad, they go to Albany. I don't have to repeat the things he says. We're building communities. Our communities are growing. They're building a lot. We're getting more population. 25,000 population. It grows during the day, and they're building houses like crazy in Saratoga County.
And our overall call volume is?
It's about 3690. We're projected 3690 for this year. Just under 3,000 transports. I think we're the 3rd busiest agency in Saratoga County. Our education phase is ongoing. You know, we got 2 big classes out of the way. We got one more Friday, and it's gonna just continue because that's what we're committed to. It's our new standard of care. Our standard of care is taking a step up, and that's what we're all about. Is there any questions on the things we sent out by email? Because it's pretty much Clifton Parks. We adopted Clifton Parks. Kevin Robert from Clifton Park, their training officer, did all the RSI training. Jay Tyler's our CIC. It's been very thorough, very backed up testing, both hands-on scenarios with a pretty difficult but fair test. So.
We have the support of Clifton Park Half Moon, we have the support from Wilton, we have the support from Anne Marie Cross at Saratoga Hospital. So does anybody have any questions or concerns for us that you want to have answered? Sam?
Todd, do you have any estimate of the number of intubations per year that you guys need to do right now?
That we're currently doing is, yeah, around 6 or so.
6 RSIs would have been done this year.
Yeah.
They've either been done by Clifton Park or Multimed or by Wilton.
Do you think there would have been more if you guys had MFI or RSI available? Like you might have delayed?
Tough to say, because we've done 21 CPAPs or, you know, different, you know, BDMs. Depends on the patient, you know.
I can tell you that I would have done one in the trailer park. I worked part-time for Malta, and there was a patient that desperately needed it, and we were able to get to the hospital, but he was definitely an RSI candidate. One of the things that Malta does, Malta Silver is going to do is train every month on it, which is more than I think most RSI agencies do. I think Clifton Park does it every month, but in Dillitland we do it once a quarter. So even if there's a low call volume there, you know, you still get the training. So.
I have one question for you, Todd.
Yeah.
And I'm all for it even as written, but this is just a question. I noticed that fentanyl is not part of your routine intubation. It's sort of an option if somebody
Mhm.
wants to do it before intubation. I'm just curious as to why. I mean,
The concern I have, and it's personally, I don't use it routinely before every intubation, and the concern I have is hypotension afterwards. So I think that we want to make it as streamlined, as simple as possible.
I guess I have one question. I think right now, because you have about 1/3 of your medics are not yet credentialed,
Correct.
the timeline for that, do you have the timeline to get there?
Well, we're not forcing them all to be credentialed. Either you're in or you're out. If you're out, and you're not gonna, you won't be performing any RSI work, but, we're not gonna fire these people. But, like I said, Friday's the next round of training. There's 6 people that are gonna be attending, so that should bring us up to 29 out of 33. And we just go with that. And, my plan is to hire paramedics that are willing to do RSI or MFI, whatever you wanna call it. And if they're not game, that's our standard of care. That's what we're bringing up to. And what I'm gonna do with the ones that aren't is I'm gonna keep beating them over the head. That's our standard of care. And they're gonna kind of wean their way out or figure out a way to go with the flow. So, I got different ways of going about that. But,
Yeah, I think once you get up to around 29 out of your
33.
Medics, now you have a good chance of always having somebody there if they need to do it.
Right.
Instead of,
in
because
worst
you
case,
need 2 medics.
we have 3 rigs 24/7 for 77 square miles. If we can't do it because the rigs in Albany are coming back from Albany and they're a ways away, we call Clifton Park and Wilton like we've been doing. We don't change, it's not rocket science.
One thing that's nice, Scott, from that perspective is, and having the endorsement of Wilton and Clifton Park as part of this, and having them work with you as part of the training process is good, because the more you standardize the care that's being provided across Saratoga County, the better it's going to be for the patients up there.
Yep.
So,
That's what we're aiming for.
nicely done.
So can you motion to approve the training?
I'll make that motion.
Second. All in favor?
Aye.
Any opposed?
Thank you.
Congratulations.
Thanks a lot.
Thank you.
Appreciate it.
Just one other thought for you. If you haven't, I would go onto YouTube of all places, find the series of video laryngoscopy trainings that were done by Dr. Jarvis, and steal them
Okay.
quickly.
All right.
Jeff has done some fantastic things in terms of intubating with the King Vision.
All right.
Very helpful.
Hospital diversion?
Hospital diversion. Yes, hold your head. So hospital diversion has classically taken 2 different pathways. Particularly with our outlying hospitals, if a hospital chooses to go on diversion, they just do, because there isn't anybody else that's going to immediately be impacted by that. Within the city of Albany, what's happened is a sort of gentleman's agreement between the institutions that they will call each other for permission to go on diversion. The problem is that this from time to time gets a very complex process of communication, obviously back out to EMS providers in terms of who's on diversion, when they're on diversion, how long they're on diversion, for what they're on diversion. And I think ultimately we need some more clarification of how this occurs. One thought that's certainly been promulgated by a couple of paramedics that have brought it to me is, you're still there. So if my patient wants to go there, they're still going to come to you whether or not you're on diversion. If there's something you can't do, tell us that all the time rather than changing your mind And if there's something that's broken, or there's a serious infrastructure problem, that's probably something that needs to be reported to the state every time it occurs and take it to another level. I think ultimately this is something that's gonna fall to the nurses committee more than anything else. But I just wanted to bring it here for a discussion from the docs, and see what you thought about hospital diversion status, and some commentary basically on the record from some of our paramedics in terms of what you think and how it impacts day-to-day services. So,
It's really been a long-standing problem that, we'll hear paramedics say, oh, so-and-so's on diversion, and hospital B knows nothing about the fact that hospital A is on diversion, or then we call and find out they came off diversion 3 hours prior, but the paramedics never got notified. But how do you notify all the rigs that are out there in the world of a diversion? I mean, unless somebody calls in and says they're coming to you, that's when they really get notified, because there's no, we need the presidential text thing for all the rigs, so that we can send those notifications out. We're on diversion because of X, Y, Z, and now we're off diversion.
They went to tones in
So by,
Albany County?
well, so by and large, I think most counties need a single phone call. I mean, Columbia County, probably Saratoga County, Schenectady County. I mean, Albany County's a little bit trickier, Rensselaer County probably for sure, Greene County for sure. Just needs a single phone call to the dispatch center to say, we're on diversion, we're off diversion. Albany County's a little trickier because you get, although the county now dispatches for far more agencies than it used to. The sheriff's office dispatches Waterville, and all the rural part of the county south. I mean, so really, even if you called the county PSAP in Albany County, they could probably notify Gilderland Colony and the city of Albany without much trouble.
Well, it's clearly not a problem that they're finding out that they're on diversion.
What's that?
It's clearly not a problem that the ambulances are finding out that the hospital's on diversion. It's
Yeah,
a problem of them coming off.
Yeah. Right.
And they do have a list.
And then you factor
The
in.
2 hospitals that I work for have a list of who to call when they're
Yeah.
on diversion, and clearly that's happening.
Yeah, I think you're right. I think it's a combination of things, and it also depends on where you work. In Columbia County, we know right away. As a matter of fact, we get 8 notifications a day that Northern Dutchess Hospital's on stroke diversion. Every time they put somebody in their CAT scan, they go on stroke diversion. So, it is ridiculous. I'm not even kidding. Greg?
Data service for
Greg, am I right? So but getting notified that they're off diversion, especially if that's a long diversion, is a real problem. If it happens at 3 or 4 o'clock in the afternoon, the night crew comes in at 6 or 7 p.m., and now the next call they do is at 8 or 9 p.m., they may not know that the other hospital is on diversion, or was on and came off, or, I mean, so there's a lot of moving parts there that makes it incredibly difficult. I don't know what the answer is, short of continuing to just notify the PSAPs and let them notify the crews.
Well, one question, pretty much everybody has a collaborative protocol app. And, I constantly get weather alerts from my weather alert. It's a push notification, so why can't we include that with the classic protocol app? Will be a push notification that says so-and-so's on diversion, so-and-so's not on diversion. And it basically will just pop up on everybody's phone who has the app. It's a little.
If only there was an app that allowed us two-way communications with emergency departments, if only one of those.
Yeah, they haven't come up
We
with that
talked
yet.
about that.
What a fascinating.
Well, at least you got what I was saying.
I think we all did.
Everybody else thinks I have a short memory, but at least you got what I was saying.
Well, I think, Don, the problem I think with push notifications off the protocol app would be getting somebody woken up a couple of times would be the easiest way for them to either remove the protocol app or just turn off push notifications.
That is true.
Right?
That is always a
I'd rather keep that one for the push notification of, we have this crisis in our formulary and we need to update this and everybody needs to look at it, and it comes very, very rarely. The idea of it being a hospital notification platform and being able to use that would be great. Obviously, that's down the line if we choose one and find a way to make that work from a fiscal perspective. In the meantime, there have been a bunch of diversions where everybody has not found out about it.
until they're calling into the hospital. And there's already a expectation on the part of the patient and the family that they're going to be able to go to one location and then being told no. I think it's very, very different if that's because there's an infrastructure problem or it's just because of volume.
Or staff.
It's because the volume,
Or
they can
staff.
still go there.
Or staff.
That's the point.
Oh, yeah.
And I think the providers need to know that and understand that.
Mhm.
What's happening is they're diverting, complex cardiac patients from one hospital to another, and the cardiologists are getting awful ticked off when their patients wind up in a different hospital, and the receiving hospital, I'm sure, is not too happy to receive these patients because they've got nothing to go with on these patients, they have no medical record. So I think that kind of has to be figured out too. Because there's a difference between diversion, like you call the state, you notify, you go through all those channels, and diversion, hey, we're really busy, so we're gonna kinda, call off a few ambulances so we can catch up, so,
In Columbia County and Greene, it's well known when everybody's on diversion or off. So we get tones dropped, whether it's 2 in the morning, 3 in the morning, 2 in the afternoon.
They tell you all the time.
And when Albany goes, we're like, what, Albany? And we check, make sure it was right. But it's always done, so I don't know what the problems are and what the, and it's true.
Yeah, I don't think the problems exist as much for
Yeah.
the southern counties as they do for up here. There's certainly more PSAPs, there's more people to notify, more people to think that got notified, but they actually didn't get notified, whatever. So, like Greg said, when Columbia Memorial has to go in diversion, like I referenced before, Northern Dutchess does it all the time. The county is the only PSAP, they dispatch all of us in the county, they hit everybody's tones at once, they make an announcement, it's done. So, it's not an issue for us really, as long as they get notified, they're good about notifying us. But again, I think we're the anomaly though. How do you notify Petersburg ambulance? And I'm not picking on them, but, they're volunteers, they're coming from home, they probably don't have a radio on. So if an alert tone gets hit in Rensselaer County and they just say it over the air without actually dispatching every agency in Rensselaer County, which how many are there? I don't know what their process is. But I bet it's not as simple as it is in Columbia County where we have 5 agencies and 1 PSAP.
Right.
Well, it used to be easy when there was Remac. Years ago when Remac was in functioning, it was very easy to notify everybody. That was a call we used to make.
It's only gonna get worse.
I think you have motions, you gotta call Tim at home.
Right.
Tim will notify all the agencies.
I think it's a great idea.
He'll have one
Make
of
that as a
the phone
motion, or-
We'll just look ahead, all in favor? Okay.
So what happens in Albany County right now? Say Hospital A calls up Albany County PSAP. What is Albany County doing with that? Are they actually calling like Medic 5 and saying that they're?
They call, yeah, right, they'll call one of us on the air and tell us. And then I'll text everybody that's on shift, hey, Albany Med's on diversion, but then like I said, at 6 PM, maybe I go off, somebody else comes on, I tell them, I don't know, man, 4 hours ago, Albany Med was on diversion, I don't know what the status is now, it's forgotten, it's lost.
A lot of the
Never
time-
mind that, I don't know that Bethlehem gets notified, Bethlehem is its own PSAP. So did Bethlehem get the same notification that Albany County got, or did whoever was making the phone calls from the hospital think that I called Albany County, that's Albany County?
And then there's Column B, you'd have to call, Bill Wilson, you'd call.
Well, that's actually
Yeah.
happened
We don't
before
know.
where, the notice has gone out across Albany County, but it hasn't gotten to any of the hospitals that were involved, particularly the Med when it's one of the St. Peter's Health Partners, in particular that direction, because that's the way I've noticed it. But I think the idea of keeping this as collegial as possible when there really is pressure that needs to come off, rather than having this at a point where the state starts looking and saying, what do you mean you're on diversion? Diversion is an official term. We need to make sure that it's being used right and it's being used well. But we've had hospitals on diversion, 1 out of 3 days so far this month, Paul, something like that? We've had some hospitals on diversion. That's a lot of diversions.
That's a lot of changes in plans in terms of where people need to go and how we
It's not
take it
using,
there.
it's not being used appropriately.
I think from the
Say it is,
perspective.
you wanna call a spade, it's not being used appropriately.
I think
It's
from the
being misused.
perspective of the,
And I'm in a really
rank and
bad spot to
file
say that.
medics that are bringing patients, I think the biggest frustration is probably the attitude that they get when they arrive at a hospital who has said that they're on diversion, but the patient is adamant that they wanna go to that hospital and they'll go nowhere else. And they're still met with, we're on diversion. What do you mean you're here? We understand. We know what it means. We get it. The patient has their rights. They're here. And so constantly having to have that headbutt with people, I think that's a very common complaint that I get back from the rank and file medics after going to hospital A. It doesn't matter which one, they're all kind of the same. when it
It's
comes
just
to
a really
that.
good thing for you to bring the
Well,
nurses committee into
absolutely.
discussion.
And me being on both ends of it, I mean, I still ride as a medic and I am still a nurse, so I see both sides of it and it aggravates the crap out of me, and I think it's being very misused right now, so it's a very, you and I have already had this conversation, a very hot topic for me. And, I will see what we can do. I think our meeting's not until November 29th, which is gonna be smack dab in the middle of starting flu season, which is only gonna be 10 times worse, but
Well, this issue isn't going anywhere, so there's plenty of time.
I have had outside conversations with many different people about this, and I'm not getting anywhere. I'm just a peon having a conversation who doesn't know what I'm talking about. So, but I think that this, I mean, education with the nurses needs to happen. I think we just got a notification too about diversion, so I'm assuming it went somewhere in administration, but it's clearly not stopping anybody from doing it. I think the wrong people are calling diversion as well. I mean, the nursing supervisor in the hospital who's there are the ones making these decisions, and that's not, the policies aren't being followed. So I don't know how we get that changed. I've tried in where I work, and I have hit a brick wall. So, I don't know what else to say.
You know, Mike, I think it's really important, the points that all of us in this room understand, the points that have already been made about there's diversion and then there's diversion that's state reportable. You know, you got an infrastructure collapse. There's no way anybody should go to that hospital, period. It's a state reportable incident, it's a structural emergency, I don't know. Exposure of a toxin, I mean, there's a whole list of things, a
Fire
fire.
in the ER, sewer backing up.
Yeah, all of that, so.
Sewer backing up, dead pigeons.
I mean, but you know, I think, to get back, I think with Scott's point, that rank and file don't necessarily understand diversion and diversion.
That's exactly right.
All right, and I think the education should go across the board, not just nursing, but it needs to be all the staff and all the area EDs regarding there's a diversion because of volume, and you know, this is sort of we're trying to divert some volume, but understand that the patient, if they're conscious and alert, have the absolute right to come to this hospital, whether we're on diversion or not, unless there's a state of emergency from a structural issue or another infrastructure issue. You know, maybe you got a gunman in the ED, God forbid, like what happened down in Ellenville. So, I mean, no one should be going to that hospital, you know.
That's why I think we should come up with different phrases.
There's gotta be a different terminology.
If you
That's
wanna have
the-
diversion, make it mean diversion like the state thinks it
Yeah.
means diversion, and come up with a different phrase.
We call it
for it.
bypass, like
because
some systems.
You know, some type of alert or some type of something so the crews understand why you're on diversion.
So your staff calling the Albany County PSAP and saying, we're on diversion. We're not on diversion, we're on diversion. Is probably not the way to get our folks in the field to have an understanding of what diversion really is. So,
So there needs
Well,
to be another word.
I think that all the area staffs need to be educated about the patient's right. In fact, that if it's not a real state diversion definition, that patient still has the right to come, et cetera. And then do we call that scenario of volume overload or whatever, some other term? Decompression, I don't know what it is, I don't know. But
It's more of a it's more of a deflection at that point than a diversion.
deflection, I
It's a
mean,
deflection, you're deflecting
I
people
don't know,
away, a
but-
diversion isn't.
but that's a thought.
You know, out west, not out west, out west of the United States, but western New York, last time I was out there, they would frequently have, and I think it was every few hours, each hospital would say they were on green, they were yellow, they were red, depending on what their bed status was. And whether that be something, you know, if you're overloaded, you're on red status. If you're okay, you're in green status, if you're somewhere in the middle, yellow, and then the medics would have an idea, hey, you wanna go to Albany Med? Well, yeah, they're probably overloaded, and you're gonna wait there for a long time. For your ankle sprain, you may wanna think about going to
But
Memorial,
what's-
because
So all
I
the
think it's a
meds
great
and
idea,
meters
but-
have been on red status since,
Well, what's the communication
last
process?
February.
You know, that's the
they
problem.
did it, basically, it would be somebody announcing it on the air, but I don't know how.
Syracuse uses the colors like that.
Yeah, and you try to avoid the one with the higher color until everybody's at that color, and then.
Well, that doesn't matter.
So what we need to do is do that, and black status is the infrastructure failure. Means don't go
Who
there.
controls those statuses though? Is it
There's
the
some,
same people that are
there's some
calling
serious
it?
motivation for the hospitals to get together on this and discuss this app thing.
And work out a pre-hospital notification system
Yeah,
that might
right.
incorporate something like this.
Yeah,
Mhm.
if only somebody had developed that.
If
already.
only somebody could do that.
Yeah, if there was only a board that we could.
It's called Tweet.
But,
Alright, so you guys will keep
That
it on the
issue is
agenda.
sufficiently beat to death.
There's one other thing I was gonna say, and that's protecting the paramedic staff or EMT staff to get beat on by hospital staff. That's where not only you notify your operations director, your medical director should hear about that. Because I know if it was any of my crew, that ED director is gonna be getting a phone call. So you really, sometimes you just have to speak up, you know, be polite to the nurse, whoever is doing that. But then you should let your leadership team know so they can then follow it up and then reinforce that.
I agree with Bruce.
absolutely. This has to come back.
Yep.
But it's stopping somewhere, because these conversations have been had.
There's the big picture
exactly
that
where
we
it's
can
stopping,
control.
it's stopping.
That'll tell
Years
everybody
of-
that's good with it right there.
Nothing happening from it. There's a frustration level in the street that, oh, well, they've got the rights and we don't. EMS very much has the feeling that we are second-class citizens, especially.
I'm there, I'm part of it too.
Absolutely, so you understand
I'm on
what I'm
both
saying.
ends of it,
You
so
come
I
through
get it.
there, you know, how often do we get the bad feedback from a hospital that, well, the nurse says that you did this, and you're guilty until proven innocent? So I can absolutely understand where that
110%
breakdown is,
agree.
because people are not gonna, they're not going to do what they consider as wasting their time by reaching out to the staff when they know that nothing's gonna get done from it. So it happens both in Albany County, because I know that we've got several specials with, special reports with folks who were treated less than professionally by hospital staff, and I know it happens on a daily basis at Albany Fire, so, how many phone calls do you want?
Don't call it anyone, nurses treating you inappropriately, you need to know that.
Well, they don't. Or they do it once, let's put it that way, they'll do it once.
Some do, absolutely.
But that's, it's one of those things that we've just reached the point that it's like, okay, when we sit around here routinely and talk about the frustration level of the nurses or the staff at the hospitals, and I've heard every excuse from, nursing, what's the, nursing understaffing, overloading, the nurses that don't actually work for them, agency nurses, travel nurses, and things like that, that you guys are routinely, you run into the same trouble that we do. Because inside the hospital, those nurses treat you like crap, just the same way they treat us. Once. Exactly. But you understand exactly where I'm coming from. You've got those same agency nurses with the crappy ass attitudes, all right? If you can't even fix it inside your doors, you're certainly not gonna fix it outside your doors. They know out of their frustration that we're easy to kick around, because they'll never hear about it again.
Still gotta bring it forward.
Now, as much as I appreciate.
I'm just saying, it doesn't even come to me anymore, Sam, that's the thing.
I know,
It doesn't even come to me
but you know,
anymore.
we say to this, to our staff,
Yeah.
when I was the director
Yeah.
at the hospital, if you're in a conflict with a patient in between you and whoever you're in the conflict with, let's get the
Knock it
patient
off.
taken
Exactly.
care of.
Right.
Knock the crap off, and we'll talk about it later, you know? And we've always encouraged people to, you have a problem, I don't care if it's EMS or it's respiratory or it's some other service outside the ED, get the patient taken care of and let's talk about it later. I think that's the same advice you gotta give to your guys out in the field. And
It's gonna take time for that to change.
I know, but
A long time for that to change, because like I said,
There are enough-
what used to come to me on a routine basis doesn't even come to me anymore. It has to truly be egregious before it's finally gonna come to us, and I mean to the point
Yeah,
where
but
they
it's
are.
a little different too, right? As a BC, you're gonna get different things than you did as a captain,
Oh, yeah.
right? So there'll be a different series of complaints that will make their way to you, all right? And one of the things to always remember for everybody in the field is if you bring me or Sam or Bruce or, you know, anybody a complaint, what's gonna end up happening with that complaint is we're gonna deal with it internally with nursing management, and you may never know that anything happened with it.
yes.
You probably will never get any feedback, because it's a
Correct.
personnel decision at that point.
That's exactly right.
You just have to know that
And
it
every one of
occurred.
those complaints that came to me got followed through. And Don can tell you, I
Yeah,
mean,
oh, I
because
have- I have
Don
no
would be
doubt about
involved
that.
with it at St. Pete's.
And perhaps the feedback,
I'm
not
sorry, I didn't
necessarily,
mean to interrupt.
yeah, not
No, no,
necessarily
no.
saying what happened, what the final disposition was, but at least knowing that once they send that in, the medical director's looking into it, or the medical director's going to reach out to the ER director, and they're going to address that. They don't even get that back, so they send it off, and it's never heard from again, it's a vacuum, and then they know 3 days later, they're going back into that hospital, they bump into the same nurse, and they're still treated like shit again.
It can
So
go
when
both
you,
ways,
when you
too.
see that it does
It
not
does.
change.
It can go both ways too.
Oh, absolutely, oh,
It can go both
totally,
ways,
absolutely,
too.
and I'm not saying that,
I don't know where we
yeah, I'm not
ended
saying
up
that our
here,
guys are
but
without fault.
It could go both ways.
Yeah, I'm not saying that our guys are not without
Yeah,
fault.
it does. It goes-
But just to have the feedback, you know,
Yeah.
thank you, you know, I had one recently where staff was not anywhere up here. It was totally inappropriate with us bringing a citation in, and we're just totally out of line. And I brought it to the appropriate people at that hospital, and they called me back later and said, thank you for bringing this to us, it's been addressed. And that's all
Yeah.
we needed to hear, to know that I'm being heard.
My other suggestion is if there's a problem and one of us is working the ED, you know, come to us right away. It's best to address it right then, not 2 days later. And that's why I say, if I'm there, if you have a problem, come see me. Or Sam, or Bruce, or Mike, or any of these guys, we'll take care of it right then and there. And sometimes it's enough just to sort of explain things to whoever that issue is. And yeah, sometimes it's both ways too, it's not just, usually it seems to be kind of, things get a little heated and then
Right.
it goes in bad directions on both sides. So, just stop it right then and there and resolve the issue.
So as for diversion, are we asking the nursing committee to work on
Yeah,
phrasing and?
I will
And-
try, we're not supposed to be meeting until November 29th. I will send out an email to Anne Marie and see if a couple of us can get that before our meeting. Because I think it needs to be handled before then.
That'd be great. Probably we
In
get
addition to nursing doing that piece, which I think is a key piece, I think another part is what does PSAP have to do with the information? That's both turning on the diversion and turning off the diversion.
I think,
So who would be the most important or most appropriate person to deal with the PSAP?
I honestly think there's an easier way to do that. I think when you're going on diversion, for instance, the last time Samaritan went on diversion, we called Albany Med and said, hey, listen, we're nuts. And they gave us 3 hours, and then it was a regroup and find out. And I think when those notifications are made, we're going on diversion for 3 hours unless you hear from us otherwise, and you have a time frame to it. And then you don't have to make those second notifications of not, unless you're still going on diversion.
I think the other problem, Bruce, it's probably a little more than that. One of the problems with the 3-hour diversion is I go off shift, you come on shift, I tell you, hey, they're on diversion for 3 hours, but no one knows
What
when
time?
it started, right? But the other problem is, as a couple of people have put really well, is each one of our PSAPs has a very different workflow and very different agencies that they're responsible for. There isn't a single pathway.
But, and that's my point. That's what I think, so we need to, it doesn't sound like we need to do a whole lot down south, but perhaps we need to do something with other areas. That's exactly my point. What do people do with that information? Some areas need work, some areas don't.
Yeah, because they do handle it differently. I know in Rensselaer County, a lot of times you get on, you say, okay, I'm on my way to Memorial, and they'll be like, oh yeah, Memorial's on diversion.
By the way,
Right.
some places what they do is.
Right.
I haven't worked in the field here, but when you get dispatched, it's, oh, by the way, this hospital's on diversion.
That's the way I would do it.
Which, so after that 3 hours mark, they have stopped telling you that hospital's on diversion.
Unless they receive another phone.
Yeah.
I think that would be a best practice.
So when you're on the way to Miss Smith's house, who's down the street from St. Peter's, they can say, oh, they're on diversion, would you like to go there, or should we go Albany Med? Up front, instead of on the way, now you're going the wrong way on New Scotland.
That would work.
And maybe the nurses committee could push for something like triage. I mean, that's clearly the system.
For what, for triage?
Yeah.
We've had that discussion,
I
and I
mean,
believe.
this is crazy, we have the technology and
So we're back to the pre-hospital notification system, and the council did authorize some funding to send some people to go look at it. I'm waiting until I'm really sure that we have the ability to implement it at the very least in the med. If that looks like it's going to move forward, which at this point I think probably will, then I'll suggest that we send some folks out and let's go see a couple of these things as they're currently being used, and find out whether or not this is something that's gonna be a tool for us here. You know, the med being the centerpiece of the puzzle, I think, is important, because if they say no, doesn't matter what else is going on anywhere else. And most of the other places seem to be have a little bit more flexibility in terms of infrastructure in the emergency department at least.
and if the med gets you, you can be sure St. Peter's is going to. So
Well,
we'll be okay.
as we had said to triage, and we actually voted on here, nobody will do this on their own. One of the things that's happened in the Hudson Valley is hospitals are using these systems sort of as marketing tools between each other. Now, that's driven some implementation down there, but at the same time, it doesn't have that collaborative implementation like would be better up here. It would probably make more of an impact more quickly.
Any more on diversion? So looking at the stroke scale, I just typed it up, so I didn't send it down to anybody, but basically what we're looking at is for the regional policy procedure would be, you have a stroke, it's Cincinnati's positive, if a comprehensive stroke center is your closest, you just go there. If your comprehensive is not the closest, then you do the FAST ED score, which you can get the app for. What we should probably do is put also just the table of what the score is. If you're low risk, you go to the closest. If you're moderate high risk, you go to the comprehensive. If you're more than 30 minutes away, if you're, whatever your score is, you go to the closest.
You're talking about low, moderate, high risk for LVO?
Yes,
Okay,
sorry.
just to clarify.
We've only had this discussion every the last 6 meetings. So
Oh,
I
yeah,
got
yeah.
ahead of
So-
it.
Just to clarify.
What's the time frame again?
Yeah, why
30
30?
minutes.
Why 30? Is that based in,
45 would be better.
in literature?
TPA time.
Okay.
It's sort of a kind of story. There's no standard STEMI. You're going to be 120 minutes from first medical contact to cath lab, stop off and get TPA. It's not that defined yet. So we went with 30 minutes as you can get something on board and then transfer from there.
This guy's question was 30 minutes, that would make it
45 would be better.
Yeah, a large portion of both Columbia and Greene County, and I assume some other counties are gonna be way outside the 30-minute
Absolutely.
window.
I mean, the idea is,
Just
you know, time to CT interpreted by the radiologist. I mean, there's a lot of steps before the TPA can be administered, so I think you have to err on the shorter side. 30 minutes is probably more appropriate.
So what we're looking at for those patients is probably about an hour from when you see them till they're getting anything, if you're gonna go at 45 minutes.
Just in case the paramedics don't know, what happens is when you stop off at hospital A, they get given their TPA there, and they get the interventional procedure done later. And the more appropriate thing is to get the TPA on board early, rather than delaying the TPA for longer transport.
There's some evidence now where the intervention may actually be beneficial for even longer periods of time than was originally thought. So getting the TPA on board sort of helps, we think, helps the treatment process.
We're told.
You know, and the intervention.
Sort of as a rescue.
Yeah, exactly. The same way that we kind of treated STEMIs. You know?
Sort of the drip and ship steady mentality.
Right, right.
Rob, what were your thoughts about people with wake-up strokes and people going out to like 12 hours? Fast ED positive straight to the comprehensive center?
Probably, because you're outside the TPA window. And that's
If
more
they're
of
large
a,
vessels.
what percentage of those do you think they'll be doing interventions on? If they'll do like 1 in 100, then it may not be worth it to do more.
At no point there was a CT perfusion scan to see if there's a number.
And they do, it seems that they have to be large vessel.
Yeah.
That would be the fast ED positive.
Yeah, fast ED positive.
So fast ED positive, wake up stroke, and greater than
Well, fast ED positive or greater than
3 hours, is that what you're saying?
No, greater than 12.
Greater than 12 hours.
But if we're outside of a TPA
Yeah, if
window,
we're outside of a
Oh, yeah.
so we say after
The end of
4 hours,
4.5.
4.5 hours
Yeah.
go. But actually, if 4.5 hours is when we can give it, if they're sitting at scene at 4.5 hours.
Yeah, it's, at the scene, it's gotta be less than that.
Let's say 4 hours,
I'd say less than 4,
3 hours.
3.5. I don't know.
By the time you get there and they get to the CT.
Yeah, I'd say at least 3.5.
So anything over 3.5 hours, just straight to the comprehensive.
I could ask you to just make a flow chart for all of this, and we can look at it and then make our final decision.
It'll be a nice big web. If the sun is in the fourth quarter.
And there's a lunar eclipse.
Any other talk on that? And I'll put this together and get it sent out, so we can check it.
So are you looking, you gotta get it done before we can formally approve it, right?
Yeah.
Which is probably good.
Done in December, is that what you're looking to do?
Because there aren't enough in these cases to make anything.
And what we have to do after this is approved by us, I think we need a number of bodies then to go to the hospitals and sit down with them, because there's gonna be a little pushback, despite the fact that it's best for patient care may not be relevant.
Yep.
So, I think there needs to be an emissary group from this body to go sit down with the appropriate CMO.
LS won't be complaining.
Pushback if they're not getting.
Yeah, there will be some pushback, the same where there was when we put together the STEMI rules. However, you know, I think the evidence is relatively clear, and as long as we make the standard that fast ED, so they can say this objectively was why this patient moved, that's clear enough for folks to be able to carry. But I think since Sam is going to be our senior emissary, that's excellent. Thanks, Sam.
I don't think you're gonna get a lot of pushback from SPHP. I've been keeping them informed about this and what's coming. I mean, I really don't.
Just making more pushback from your guys, actually, people arriving who they don't think they're doing.
Be proactive in just verbalizing what we're gonna do, I think would just be politically a very good thing.
FYI.
Oh, I agree.
Over for everybody.
Well, the nice thing is that the stroke folks
actually been having a lot of
They've
really
been-
open comments
they've
about
been
this.
in the community hospitals a lot.
With the community hospitals, and the community hospitals have been very active in that stroke advisory process, so.
I don't know if I like the term senior so much. Anyway.
For elder statesmen?
Elders worse.
Pick your boy experience.
Experience statesman. Okay. Don, you're on here for advanced care
I have
plans?
nothing to add to that.
Okay.
We got an English
It's
teacher.
DNR. Any new business?
One thing I just want to tack on was, since we just wrestled the BVM thing down, and actually Scott made a comment that brought something to my head. And that's discussion, if you've noticed the wells that EMS get replaced with at the hospitals, they're super micro bore. So here we put in a large bore line. We promptly take and put 5 inches worth of something micro bore, and then attach it to a big bag and turn it wide open. It's kind of ridiculous. Every hospital has the large bore F wells. You may have to ask for them, but they do exist at each and every hospital. I have looked and I have found them at every hospital. If we could work on getting those that are put in their Pyxis or however they do their replacement for EMS, completely abandon all micro bore. There is never an indication, and use the large bore F wells. And then over time, everybody will be using large bore wells. I mean, use up what you've got in your bags, but eventually it'll all become large bore wells.
Got it, I wrote the note.
Welcome to the party, Bruce. We've been saying that for a decade.
Yeah, I know.
Thank you.
I'm just making it happen. Well, what happens now, I go to calls and I'm actually handing Scott mine. I say, use this one, use this one, use this one.
Actually, I just skip it if I need to give it forward.
That is.
A couple of other things under new business. First of all, the Hudson Mohawk Marathon is this weekend. So if you bring that back to Samaritan Memorial and St. Peter's Health Partners, that would be great. ASAP updates, just quickly if I may. Spent a bunch of time when I was out in San Diego just getting a better sense of where the federal agenda is right now, and some of the lobbying that ASAP has been doing on our behalf. They actually had a really successful year last year, particularly with some of the regulatory work around the DEA rules for standing orders and other things were impacting us directly. They are actively continuing to push with the FDA on drug shortage solutions, although obviously we haven't come up with a strategic answer to that yet.
Remind me of drug shortage, because we're not getting Benadryl, that's gone. Do we need to come up with a replacement for that?
Gotcha. In terms of other things, if you have been following the NHTSA 2050 project, that is out there, and you should be able to take a look at one of the drafts of that. The National Scope of Practice model is coming out as a revision that will be here in late 18 or early 19. And do take a look at EMS Compass. Those things all come from NHTSA as things to take a close look at. One other law that's coming along is going to be something called Carey's Law, which is actually going to require the removal of leading numbers for 911. So for example, if you're in a hospital and normally you dial 9 and then 911, it's actually just 911 will be required to work. They anticipate implementation of this over the course of the next 5 years. So wherever you are, you'll be calling 911 and you'll get 911 services, which may or may not be an interesting process.
Especially since.
I hope your internal
dial
extension is
911 and get the code
917.
operator in hospital.
Exactly. And the other thing actually that came from FEMA is have some of your more enthusiastic participants take a look at what's available in Anniston in particular, which is a place where they have a National Health Preparedness Training Center, which is down in Alabama. The trip to Alabama is free, housing in Alabama is free, and the training down there is fantastic. And they're just looking for more people to participate down there. So a lot of very interesting training down there. And that's it.
Old business?
Old business, since Dr. Stanger is here, I would like to bring up the cost of a remote signal.
Yeah.
Yeah, let's talk about that.
We haven't met yet.
I'm only
You
kidding.
did schedule something.
It's important to poke Craig at least once during every meeting.
Absolutely, I haven't seen him in a while.
Motion adjourned?
I'll move it.
Okay.
From our experience.